No problem, no problem. We will start it. Huh? Yeah, okay, it is coming live. So, no problem, no problem, Kati. Just my audio is fine, huh? In the live, you check out. No problem, no problem. We will start it. It is coming. Okay, I'll start it, Kati. Thank you, thank you, thank you. So, good evening, welcome Defi Andhra, Andrea and Suman Barik, welcome all. Just opening the other device for the class. Okay. So today we are going to discuss a new topic, second test. I think you all have written the exam very well. So the second test series for discussion for today is related to head and neck, thyroid and breast. So I told you this is a 25 question test series. I wish you all to attend the test series. Only after attending the test series, when you come for the exam, it will be nice to attend the exam, attend the class. Okay. So let us start the questions in just 2 more minutes. And how was the exam? The exam you wrote is very tough or easy. Actually, I made the first exam very tough, and second exam I made it very easy. And tomorrow you are having gastrointestinal tract. Third test that is going to be very, very tough. That is a real tough exam based on INI set pattern and also the latest NEET and next pattern. I think this test you all would have answered very well because most of the questions are recent questions and very easy questions, I think. So, how do you feel whether the test is easy or not? I hope all of you attended the test series. 25 questions from app in DocTutorials. Okay, if you have not attended, please, you must attend the test, then only you should come for the class. Then only it will be easy for us to finish in 1 hour. Otherwise, it will take more time and it will be waste of time for you if I am going to explain every concept from basics. This is a test series made for INI set exam. In-depth discussion will be there, okay? So let us start with the question. The questions all are taken from mostly Bailey and Love, a few questions from Sabiston. So the first question is regarding branchial cyst and sinuses. True statement is, please remember, this is a question on branchial cyst. Off easy, off tough. Okay, Daffy. So, but all the questions are from Bailey. Many questions will be repeat questions also from AIMS exam. So I'm going to now discuss about the branchial cyst from Bailey and Love. The branchial patients are recognized at birth itself. See, please remember, branchial cyst, you know very well, it's arising from the pharyngeal arches. The patients are recognized in birth itself is totally wrong. Though it is a congenital branchial cyst, they usually present after some time. Okay. Second question, first branchial remnant is present behind the ear. Behind the ear or preauricular is correct. Okay, preauricular is correct. Second branchial remnant is the least common type is wrong. It is the most common type. Third branchial cleft is seen anterior to sternocleidomastoid. In the upper third is wrong. All the above remnants open in tonsillar fossa. So let us discuss this question on very clear question on branchial cyst, and the questions taken only from Bailey and Love. This question is a question from Bailey and Love. Let me explain it. With picture it is there in Bailey and Love. So as you all know, these are the branchial clefts. How many pharyngeal arches are there? These are the 5 pharyngeal arches you know very well. 1, 2, 3, 4, 5, 6. The 5th arch will disappear. Very basic question. 5th arch will disappear. And usually what happens is the 2nd arch will go and fuse with the 6th arch like this. The 2nd one will go and fuse with the 6th arch and creates a pouch here that is known as pharyngeal pouch. So congenital pharyngeal pouch. Usually after birth, this pouch will disappear. If this pouch is persistent, it is known as branchial cyst. That is known as branchial cyst. So if the 2nd to 6th arch, there is a pouch which is present, which is persisting even after birth, it is known as branchial cyst. Please don't forget it. It is known as branchial cyst. If it is remaining open, it is known as branchial fistula. So I hope you all know when you are reading the basic questions, branchial cyst presents as a swelling in the upper third sternocleidomastoid muscle. Branchial fistula congenitally presents as an opening in the lower part of the sternocleidomastoid muscle. and branchial fistula will run from here and open into the tonsillar fossa. It runs and it opens into the tonsillar fossa. Please don't forget, it will open in the tonsillar fossa. So second is the commonest anomaly. Sometimes the first one can form a branchial cleft and that can remain as a persistent sinus, and the first branchial residual will present in pre or post auricular area. Please don't forget, first arch remnant, the first arch remnant will present as a pre-auricular or post-auricular opening, and that's a very important thing. And the third arch remnant will present as a opening over the sternoclavicular joint. Over the sternoclavicular joint, it opens as a small hole here. So please don't forget where are the openings of each branchial cleft. Usually the common questions which we used to discuss is second one only. So second one presents as a swelling in the upper third of sternocleidomastoid, opening in the lower third of sternocleidomastoid, and third one presents as a sinus opening in pre-clavicular area. Pre-auricular and post-auricular is first one. That's the explanation from clear-cut Bailey explanation. So the third branchial cleft remnants usually do not have sinuses or fistulas and are located in the suprasternal arch or clavicular region. The third one usually contains cartilage and present clinically as a firm mass and subcutaneous mass. Okay, so this is the first question, very simple question on branchial cyst, but I made the choices little complicated so that to make you confused. Otherwise, the question is very straightforward question. First opening here, second opening here, third opening here, the clavicle. Okay, please don't forget the opening places of each remnants or the swelling of each remnants. So this is again another tough question from Anatomy of Bailey and Love. So all these questions are from Bailey and Love, and all questions are highly expected ionized questions regarding the recurrent laryngeal nerve. So please remember, please simply read the question, you can answer by excluding many questions. So left recurrent laryngeal nerve will hook around the arch of aorta. Right recurrent laryngeal nerve will hook around the right subclavian artery. Please remember, right side sometimes you can have non-recurrent laryngeal nerve. Means what is non-recurrent? So vagus nerve gives the branch recurrent laryngeal nerve. It will go down and recur up. That is known as recurrent. Going down and coming up is known as recurrent. If it is not going down and directly appearing, it is known as non-recurrent laryngeal nerve. It is seen on right side commonly. 2% time it will not go and hook below the subclavian artery. It will directly come to the thyroid area. Okay. So second B choice is also correct. The nerves enters at the cricothyroid joint at the level of berry ligament. That is true. The nerve enters at the level of cricothyroid joint at the level of berry ligament attached. But the point is, this is not the most common site of injury of recurrent laryngeal nerve. So most common site of injury of recurrent laryngeal nerve is given at Beer's triangle. So Beer's triangle is a very important triangle. This question is, I am stressing to make you understand what is Beer's triangle. So Beer's triangle is bounded by three structures. Medially, tracheoesophageal groove. Okay. Superiorly by inferior thyroid artery. Okay. Superiorly by inferior thyroid artery. And another one boundary is common carotid artery. That triangle is known as Beer's triangle, and this nerve can be identified after mobilizing the thyroid gland lying at the most posterolateral portion of the gland known as tubercle of Zucker-Candle. It is correct. It is Zucker-Candle is a pointing tip of recurrent laryngeal nerve. So that is correct. So D is wrong. This nerve is not a content of Beer's triangle. It forms the medial boundary of Beer's triangle. So the most common site of injury of recurrent laryngeal nerve is in the Beer's triangle at the point of entry into the cricothyroid joint. So let me explain you this with an image. So please understand, this is a thyroid gland. You all know very well the recurrent laryngeal nerve is going to coming from below and going to enter into the tracheoesophageal groove area. So this is the trachea, and this is the esophagus. So this groove is known as tracheoesophageal groove. The recurrent laryngeal nerve is running here, is forming one boundary. It enters at the level of cricothyroid joint. It enters near the posterior berry ligament attachment, near the cricothyroid joint. It enters into the trachea. At the level of cricothyroid joint, it enters into the trachea and it is supplying the mucosa below vocal cords and all the vocal cord muscles except cricothyroid muscle. This is one boundary. So please remember, the other boundary is common carotid artery going like this. Another boundary is inferior thyroid artery, common carotid artery, tracheoesophageal groove. So please don't forget, this triangle is known as Beer's triangle. So Beer's triangle is a triangle formed by three boundaries. Medially, tracheoesophageal groove containing recurrent laryngeal nerve. Superiorly, inferior thyroid artery. Laterally, common carotid artery. The most common site of injury of recurrent laryngeal nerve is given in books in Bailey and Love is known as Beer's triangle. In some books, it is not mentioned Beer's triangle, but it is this triangle I am drawn here is actually in this place. So this another point is at the point of entry into the cricothyroid joint. So both are correct. Either the Beer's triangle is also correct into the point of entry into the cricothyroid joint is also correct. So the answer here is D. Left recurrent laryngeal nerve hooks around the arch of aorta. Right nerve hooks around the please remember, left nerve hooks around the arch of aorta, right around the subclavian artery. 2% time you may have non-recurrent recurrent laryngeal nerve. So the nerve enters at the cricothyroid joint at the berry ligament, and this is the most common site of injury of recurrent laryngeal nerve. The nerve can be identified as a boundary, not a content. Please remember, not a content of Beer's triangle, and this is common carotid artery, inferior thyroid artery, and recurrent laryngeal nerve, as I have shown in the diagram. The nerve can be identified after mobilizing the thyroid gland, lying at the most posterolateral portion of the gland known as tubercle of Zucker-Candle. So this is a little complicated question, but highly expected MCQ. This question is directly the second paragraph of thyroid chapter in Bailey and Love. That much it is important to know the recurrent laryngeal nerve anatomy and the Beer's triangle anatomy. Okay, please don't forget this. So this is an image-based question actually from Bailey and Love. I used to take this question as an image-based question. Regarding tracheostomy, false statement is what? Regarding the tracheostomy, false statement. So this pure question from Bailey and Love. You must know, elective tracheostomy, the incision made is horizontal incision. Okay, elective tracheostomy, we make an horizontal incision. Emergency tracheostomy, we make a vertical incision, no doubt in that. And sometimes some surgeons will use a special type of flap when I am doing a vertical incision. Please don't forget, when we are making a vertical incision like this, we make a flap using this second and third tracheal ring. This will be created as a flap like this, so that I can easily insert the tube whenever I want to take and out. I can easily insert the tube. That flap is known as Bijorg flap. That Bijorg flap should not be done in children. It should be done only in adults. Please remember, it should be done only in adults. So Bijorg flap has advantage of reintroduction of the displaced tube. When the tube comes out, we can easily reintroduce. Percutaneous tracheostomy is rarely performed in children, and in pediatric patients, vertical incision made between the second and third rings. So the wrong answer here is B. This is a Bijorg's flap. Can you see? This flap is very clearly showing you the cut of trachea is fixed to the skin, sutured to the skin. It is like a flap. Now I can easily insert the tube every time inside and out by a Bijorg flap. So Bijorg flap is very important flap for your exam. This is actually an image-based question. For elective tracheostomy, transverse incision is made in the neck. Emergency, we make a vertical incision. Whatever may be the surgery, trachea will be opened vertically at second and third rings in children and adults. Second and third ring is the place where we open. Inferior based flap known as Bijorg flap is used only in adults and should not be used in children. So percutaneous type of tracheostomy is not advised in, is rarely performed in children. What is this percutaneous type? It means nothing but needle cricothyroidotomy should not be done for pediatric cases. Needle cricothyroidotomy, needle tracheostomy and all should not be done because it will cause subglottic stenosis. Subglottic stenosis can happen. You should not do those things. Okay. So coming to the next question on classical question on correct pairing of neck nodes. So let me discuss the question before, let's discuss the concepts before coming to the question. So I hope most of you would have read this level of neck node questions. Level of neck node questions. So how many levels of neck nodes are there? Please tell me what is the number of level of neck nodes we have. So I'm telling you, this series is purposefully made for people who have already prepared well and appearing for INI set and also for NEET SS with NEET PG exams with so much of confidence, definitely you should attend this series because all the questions are specifically made to appear for INI set. So level 1 nodes are submental, submandibular. This is level 1. Level 2, level 3, level 4. Level 2 is upper jugular, level 3 middle jugular, level 4 is lower jugular. Level 5 is posterior group of nodes. Level 6 is pretracheal, prelaryngeal nodes. Level 7 is upper mediastinal nodes. This is a simple classification. For an FMG exam, this is enough. Submental, submandibular, upper jugular, middle jugular, lower jugular, posterior group, pretracheal, in the superior mediastinal nodes. So now you should know how to make what is the correct landmark means. We take certain points. This is the angle of mandible. Okay, base of skull. Base of skull. Base of skull to hyoid bone is level 2. Base of skull to hyoid bone level is level 2. Hyoid bone to cricothyroid muscle. This is level 3. Cricothyroid to clavicle is known as level 4. So please forgive me for the handwriting because this is the one problem with the OBS software. We cannot make this writing in a line down. I have to write in a different place. It has to come like this. So I will try to do next class in an iPad so that I can write and explain you. So level 1 is submental, submandibular, upper jugular, middle jugular, lower jugular. Upper is between base of skull to hyoid. Middle is hyoid bone to cricoid. Lower is cricoid to sternal. 2, 3, 4. What is we call it as 6? 6 is from hyoid bone to clavicle. See, from hyoid bone to clavicle in the midline is known as 6. Yes. 5 is behind the sternocleidomastoid muscle. Simple classification. But unless you know the answer, you cannot answer it correctly. Okay. So correct pairing of notes is level 3 is cricoid to clavicle is wrong. Okay. Level 3 is not cricoid to clavicle. What is level 3? Level 3 is between hyoid to cricoid. Hyoid to clavicle is not level 4. Hyoid to clavicle is level 6. Level 5 is base of skull to cricoid is wrong. It is base of skull to hyoid is level 2. Hyoid to cricoid is level 3. Cricoid to sternal is level 4. Level 6 is hyoid to clavicle. Pretracheal, prelaryngeal nodes. Please don't forget this. Please read the explanation provided in the elect test series. From the elect test series, you should go through the explanations. You will definitely get a good idea about the explanations. I have given all the explanations in detail. That's a third. That's a fourth question. Fifth question is, these are all questions you should never make mistake because these are all typically repeated questions, not new questions. So anybody answer this question? Post superficial parotidectomy, a patient developed numbness in the cheek area. Which nerve is injured in surgery? There are 3 important MCQs from nerve injuries. Okay, the answer for this is greater auricular nerve is the most common cutaneous nerve injury. The cutaneous nerve, sensory nerve near the parotid area is greater auricular nerve. It supplies the shaving area in the cheek. Okay, this is shaving area in the cheek. Auriculotemporal nerve, you all know very well, it is a branch from the cranial nerve. It is a parasympathetic post-ganglionic nerve. What will happen if it is injured? It will cause, yes, anybody? I am not seeing any of you answering there. Please answer so that I will know you are attending the session clearly. Yes? Yeah, the answer for this greater auricular nerve answer is auriculotemporal nerve answer is Fraze syndrome. Okay, Fraze syndrome. Fraze syndrome is due to injury of auriculotemporal nerve. Then what is the most common nerve injured? Overall most common nerve injured in parotidectomy. Most common. So please remember there are 3 questions. Most common sensory nerve injured is greater auricular nerve. Most common post-ganglionic sympathetic nerve injury is Fraze syndrome. And very good, Zaim Patel, Fraze syndrome. What is the most common nerve injured? Overall answer is, most common nerve injured overall is facial nerve branches. Please don't forget facial nerve branches. Very good. Very good, Duffy Andrea. That's correct. Fraze syndrome. So please don't forget the only cutaneous nerve injured is greater auricular nerve. All others are motor nerves. Okay. 6th question from a thyroglossal cyst. Thyroglossal cyst is a midline swelling seen most commonly below the hyoid bone. It is a congenital cyst arising from the arising from Thyroglossal tract. Okay, please don't forget Thyroglossal tract. Very good, Shagar. That's correct. So there is a little delay of answering from your side because of the network issues. So don't worry. So now Thyroglossal cyst is a very basic question. You should not forget. Thyroglossal cyst secondary infection leads to sinus. Yes, absolutely true. Thyroglossal cyst, the commonest complication is infection that leads to thyroglossal fistula. Okay, or sinus. 70% of the time, the thyroglossal cyst will contain thyroid tissue. Don't forget, 70% of the time thyroglossal cyst will contain thyroid tissue. That is why we always do thyroid scan in pediatric cases, because if it is the only thyroid tissue, if I remove it in a pediatric age group, they will land up in what? They will land up in permanent hypothyroidism. Therefore, ectopic thyroid tissue should be found out in cases of pediatric cases before surgery. It resolves spontaneously. No, it will never resolve. It will never resolve. Once thyroglossal cyst is seen, we have to operate. The surgery is known as cyst trunk operation. You should operate. Okay, cyst trunk operation. Thyroid glossal duct, usually in congenital lifetime, it obliterates by 10th week of intrauterine life is true. It is lined by stratified squamous or ciliated columnar is also true. Please don't forget, thyroglossal cyst is a very important question for your exam. The cyst is lined by, please understand this line, cyst is lined by pseudostratified ciliated columnar epithelium or squamous epithelium. Sinus is lined by columnar epithelium. Sinus means the fistula or the cyst getting ruptured and goes for opening will develop a sinus. Okay, don't forget this point. Ectopic thyroid tissue is found in 65% cases. Found in 65% cases. The thyroglossal duct arises from foramen cecum and disappears by 10th week. The common age is around 5 to 10 years. Once they appear, it is rare for resolution. They won't resolve. They won't resolve after it is appearing. Okay, please remember this question. 40 years female had a carcinoma breast and surgery is done. During the surgery, the surgeon ordered frozen section study. This procedure will be useful for all except whom this procedure will not be useful. So please don't forget, surgeon has ordered frozen section study. This procedure is useful for all. So frozen section is a test done during surgery. Please remember, and we need the result during the surgery itself. I cannot wait for the result to come for 1 day or 2 days or 3 days. I want the result to be obtained immediately. So to obtain the result immediately, what should I do? What are the cases I need like that? Number 1, when I do sentinel node biopsy, I want to know whether I can do axillary dissection or not. Such cases I will do frozen section, number 1. Number 2, if I am doing a breast conservative surgery, please remember, breast conservative surgery is a surgery in which I am not going to remove the entire tumor. I am going to only remove a part of the tumor with a small part of the breast containing the tumor with a margin. So I want to be sure all these 4 margins are negative after removal. So such times I will take these margins, I will be sending for frozen section to confirm there is no malignancy. So the only 2 places during surgery is to be done for frozen section at the margin, and another is frozen section of the sentinel node. So margin positivity answer is correct, true. Sentinel node study is true. For confirming the malignancy in the node showing high activity in gamma probe is nothing but sentinel node biopsy. For confirming the diagnosis of cancer is wrong, because we would have confirmed it's a cancer before surgery itself. We are not going to confirm it is a cancer, especially in a breast cancer. This scenario of confirming the diagnosis of malignancy intraoperatively may happen during pancreatic surgeries. During pancreatic surgery, sometimes if you have a doubt, especially when you are doing a phrase procedure, at that time if you have a doubt it can be a cancer, that time you can take a tissue and send for frozen section. Not always, only for cancer pancreas it can be used, not for breast. Okay, that's not used for breast. So please don't forget this question with the detailed explanation given there. Don't forget to read the explanations from the app. A female patient with a lump presented in the right upper outer quadrant, 4 into 3 centimeter. Can you tell me what is the T staging of cancer? 4 into 3 centimeters. It is T2. Less than 5, less than 2, 2 to 5, more than 5. That is a centimeter. So this is T2. T2 is 2 to 5 centimeters. So this comes under T2. Axillary nodes are negative. Please remember, nodes negative. Mammography reveals BRATS 4. Patient underwent BCS surgery, breast conservative surgery. Final HP report is not cancer, it is ductal cancer in situ with a high grade. So, high grade ductal cancer in situ. Can anybody tell me what is the grading system used for ductal cancer in situ? Anybody? What grading system is used in ductal cancer in situ to proceed further after a breast conservative surgery? So please remember, duct cancer in situ, the treatment is either breast conservative surgery or simple mastectomy. After doing this surgery, I should know whether I should give radiotherapy or not, because hormone therapy will be definitely given. Hormone therapy will be given, definitely will be given. Hormone therapy will be given. Radiotherapy, will it be given or not? It is done by one study, one thing known as Van Nuys grading. Very good, Shekhar, very good. Van Nuys grading score is used, and based on that score, if it is high grade, we should give adjuvant radiotherapy. Simple question. So if there is a Van Nuys grade showing you high grade, we should give adjuvant radiotherapy is the answer for this question. So Van Nuys grading system says this case needs adjuvant radiotherapy. That's all. What is Van Nuys grading system? Van Nuys grading system is based on patient age, the type of ductal cancer in situ, like there are many types like pleomorphic and other types, presence of microcalcification, margin resection, size of lesion. Based on this, we have a grading system known as Van Nuys grading system. If the grading system is high grade, we have to give radiotherapy. This is from Bailey and Love only. Please remember, every question is from Bailey and Love. Especially if you are final year student who are attending these classes, you must go back and see what are the points I'm telling you are there in Bailey and Love. You have to mark them in Bailey and Love because these are all high yield, NEET PG or future next questions also. So this is a Van Nuys grading system showing you patient age, ductal cancer in situ, microcalcification, resection margin and size of lesion. We have to give radiotherapy for this case. So many questions will come from staging of breast cancer. You must be thorough with all the staging. Okay. First of all, any cancer you are given, you have to come to the grading, the TNM staging. Then only we can plan further discussion. 45 years old female, breast mass 4.5 to T3, that is T2. Left upper quadrant of the right breast, which is not fixed to the pectoralis major, no skin changes. So it is T2 only, no skin change, no muscle fixity. So it is 2 into 1.5 size single node in the right axilla, it is mobile node. It is N1. So no mass in the opposite breast. What all investigations will you do? So T2N1 cases is a case of early breast cancer. T2N1 is a case of early breast cancer. Please don't forget, T2N1 is a case of early breast cancer. What all things to be done in early breast cancer? Number 1, in an early breast cancer, we will do mammography, no doubt. PET-CT is not advised for early breast cancer. It is advised only for locally advanced, means T3 and above, N2 and above. Only these cases we will do this staging. Okay, we should not do it for early breast cancers. Please remember, for locally advanced breast cancers, we will be doing that. Will I do biopsy of breast mass? Yes, I should do biopsy of breast mass. Ultrasound guided biopsy of axillary nodes is never ever advised. If there is an axillary node in a cancer case, it is a cancer unless proved otherwise. No need of any biopsy to confirm it is a node. In no cancer we do like that. In no cancer, including oral cancer, see a penis or whichever cancer, if there is a cancer, there is a node, it is cancer node only, unless otherwise proved. Okay, there is no such protocol known as ultrasound guided biopsy of axillary nodes. Such ultrasound guided biopsy of axillary nodes is no more advised. Okay, so please remember the investigations done for this case is mammography and biopsy of breast mass. That's the two answers here. 40 years old female has a massive enlargement of right breast. You can see she is having a massive enlargement of right breast. This is an image based question. It shows redness. Okay, redness. It cannot be mastitis because she is a 40 years female. If it is a mastitis, they would have given a clue, lactating female. But this is not mastitis. It is a 40 years female. 30 days it is present with a red enlarged breast. It is mobile over the chest wall. And local rise of temperature is seen. So classically this is a case of what? Inflammatory breast cancer known as T4D. So T4D, very good, Anshul Sharma, that's correct. It's a T4D inflammatory breast cancer. I will tell you 2 points you must not forget for inflammatory breast cancer. First point, it is inflammatory breast cancer because within 30 days to 3 months maximum, the breast becomes enlarged, red and inflammatory appearance. That is the first point. Number 2, when I palpate the mass, I cannot see a tumor there. It will be fully inflamed, fully thickened. Skin will be very thick. So if I try to palpate for the mass also, mass will not be seen. Even in mammography, you may not see a mass. Please remember, inflammatory breast cancer, even in mammography, you won't see a mass. Then how to diagnose this cancer, inflammatory breast cancer? Very simple. Take biopsy from the skin. Dermal biopsy, skin biopsy. Skin biopsy will show you tumor infiltrating the skin. Tumor infiltration to skin is seen. That is a very important thing you should not forget in inflammatory breast cancer. Please don't forget the fourth point. There may be no abnormality in mammography beyond skin thickening, and a palpable mass is not required for the diagnosis. Many times you cannot palpate a mass. The pathological hallmark is presence of cancer in the tumor cells within the dermal lymphatics. So tumor cells should be present in the dermal lymphatics is a clue to confirm it is a cancer. It's a very poor cancer. Extensive meds will be there. You have to give neoadjuvant chemotherapy. Question number 11 is an upcoming question, very commonly asked exam question in most of the exams related to laparoscopic anatomy of inguinal hernia. We have a separate module explaining about the laparoscopic anatomy in our app. So you should go through that video of the triangles. Let me anyhow explain the importance of triangle. So triangles this is since a short session, I cannot explain everything in detail, but let me tell you important clues which you should go through when you are getting a free time. This is iliopubic tract. I am seeing from above. This is scrotum, penis. This is iliopubic tract. Okay, this is peritoneum, which is a reflected peritoneum. Now I am going to show you the various contents entering this deep ring. This is deep ring. So this is first important thing you should not forget. Vas deferens which enters the deep ring. Vas deferens enters the deep ring. And testicular artery and testicular vein will enter this. Second, testicular artery and testicular vein enters. This is testicular artery, testicular vein. So now you can see we have completed the 3 triangles. So there are 2 triangles. This is what triangle? Triangle of doom. Okay, triangle of doom. This is triangle of pain. Simple, that's all. What is triangle of doom boundaries? Now can you tell me what are the boundaries of triangle of doom? Triangle of doom bounded by vas medially, gonadal vessels laterally, peritoneum inferiorly. Triangle of pain bounded by gonadal vessels medially, iliopubic tract laterally and peritoneum inferiorly. So what are the contents of triangle of pain? Lateral cutaneous nerve, femoral nerve, femoral branch of genitofemoral nerve, anterior cutaneous nerve are the 4 nerves present in this. That is why it is known as triangle of pain. Any injury can cause severe pain. Okay. Yes, Anshul Sharma, you have to take a full biopsy, full thickness biopsy from the skin. Using a true cut also, you can take a biopsy from the skin. And this is triangle of doom containing external iliac artery, external iliac vein, both are seen. So more dangerous. External iliac artery, external iliac vein are seen. This is known as the true triangles, triangle of pain and triangle of doom. Don't forget these 2. So medial boundary of triangle of doom is vas deferens. Yes, it's correct. As I told you in the picture, I draw, it is correct. So answer 1 is correct. Lateral boundary is iliopubic tract of triangle of pain is correct. That is also correct. Myopectineal orifice is an orifice which you see from inside. Okay, please remember, this is such an orifice. You have all the openings, indirect opening, direct opening, femoral opening, everything will be seen from inside. Usually we keep a huge mesh in this orifice only from laparoscopy. So this is bounded by, C is correct, D is wrong. Let me show you the image. See this myopectineal orifice of Fruchard. Medially it is bounded by rectus abdominis muscle. Above it is bounded by conjoint tendon muscle. So you can see this is a normal anatomy only. Rectus abdominis, conjoint muscles from the back side, and laterally you have a iliopsoas muscle. Inferiorly there is bone, pecten pubis bone. Okay, pecten pubis, conjoint tendon muscles like internal oblique and transverse abdominis, iliopsoas sheath, rectus sheath. All these are forming one orifice known as myopectineal orifice of fruit chart. So please don't forget this question. Mesh for hernioplasty should be ideally what type of mesh you should use. So all of you know the basic points about mesh. Mesh is made up of proline. Proline is a non-absorbable material. It is white in color. It is used in all hernias to prevent recurrence. Okay, so therefore what type of mesh is better to be used? Using proline, the mesh we should use should be having a large number of holes, large hole meshes. So large pores like this, and mesh should be thin mesh, lightweight mesh. Lightweight means the mesh is less than 40 grams per meter square, and it should have a large number of pores. So it is small weight, large pore is the correct mesh use. It's a repeat question. All these are repeat questions. So please don't forget, lightweight mesh 40 grams per meter square is a mesh which is ideally good, because when I'm keeping a mesh on a hole like this, if I keep a lightweight mesh, it won't shrink more. If I keep a heavyweight mesh, it will shrink and it will go inside the hole and it will cause recurrence. So lightweight mesh recurrence is less common. There is less shrinkage, better tissue integration, more flexibility and comfort for the patient. Pain is less. If you keep a heavy mesh, it will cause more pain also. Okay. A female patient with a problem in the breast. What is the reason for this presentation? So very well known question. It is a Peau d'orange. Peau d'orange is nothing but what? T4B. T4B is known as skin involvement. All skin involvement like Peau d'orange. Peau d'orange is one mesh. What else? Peau d'orange is one finding. Ulceration, satellite nodules. If these are seen, it is T4B. Please remember, this is a case of blockage of subdermal lymphatics, T4B. Okay. Simple question. By large holes we feel light. Yes, large pores we feel light. That's correct only. Yes. Another question from breast. A patient underwent mastectomy for carcinoma breast and presents with upper limb swelling after 3 months. What is your diagnosis? Another simple question. These are all easy questions. Some of you told 50% questions are easy, 50% questions are difficult. These are easy questions. So patient having a lymphedema of the arm, upper limb lymphedema. So upper limb lymphedema is characterized by fullness of the limb. Stemmer sign will be positive. Stemmer sign means inability to pinch. And if it is going to be there for long period, it may go for lymphangiosarcoma also. But this image is a case of lymphedema. Lymphedema incidence has come down now because we are not doing radical neck node dissection plus radiotherapy together. So answer is B. Very simple. It can occur from any time, months to years after treatment. It is a rare complication of lymphedema is lymphangiosarcoma known as Stewart-Trevis syndrome. So another easy question from our content only. Same question from our content. Can you tell me what is this? A patient had a left mastectomy. Can you see? This lady had a left mastectomy. Following a left mastectomy, she had a reconstruction in the form of a breast by using some tissue. So you can see there is an incision in the lower abdomen. You can see this incision is involving only the lower abdomen, means they have taken some tissue from here. Okay. They have taken some tissue from here and they transferred it here. This type of flap is known as DIEP flap. Deep inferior epigastric perforator flap based on inferior epigastric artery. It is a free flap. The free flap, they have kept this inferior epigastric artery here and they have anastomosed with some of the arteries nearby. So with some of the arteries like internal mammary artery, some artery they will anastomose. Inferior epigastric artery based flap known as DIEP flap. Answer is B. Very good, very good. And Daffy Andrea, it's correct. And Shul, it's correct. Which type of cancer breast has mucin on biopsy? Presence of mucin. Mucin positive. There are many types of cancer you should know. No specific type is the most common type. Medullary type is a type of cancer which is triple negative, means ER negative, PR negative, HER2 negative. So that is another one type. And tubular type and colloid or mucinous type. Colloid or mucinous type is good prognosis of all. Good prognosis of all is colloid or mucinous type. So these are the basic pathologist classification. Basal type of classification comes under molecular classification. It is different. I am not going to that. So medullary tubular colloid, which is containing mucin, means it is colloid cancer which contains huge amount of mucin. So drug of choice for severe mastitis. What is the drug of choice for severe mastitis means? Answer is cloxacillin. So mastitis is very common in lactating female. Drug of choice is cloxacillin. So these are straightforward questions. Mastitis caused by staph aureus. Drug of choice is flucloxacillin or cloxacillin. A 14-week postnatal woman presents with a fluctuant breast swelling. Please remember, in the breast there is a fluctuant swelling. So fluctuation is a sign of abscess. How will you treat the abscess in the breast? When I was doing MS general surgery or even up to past 10 years back, we were doing incision and drainage. We will put one incision here, another incision here, drain the abscess. That concept is gone in new books. Repeated aspiration under ultrasound guidance with antibiotic cover is a latest answer. So it is a minimally invasive procedure. No, it is not analgesics. It is not analgesics, it's not the correct answer. We will be giving analgesics, but what is the treatment means? We have to go for incision and drainage was advised if it not resolves in 48 hours in olden days. Latest recommendation is repeated aspiration under antibiotic cover. If needed, ultrasound guidance. This allows resolution of the abscess without incision drainage. Meanwhile, you can also use that same breast, infected breast can be given for the babies to feed. Milk also can be given through that breast. So these are the points, changed concepts. These are changed concepts in new edition Bailey. So this again already discussed question. So you can see this lady is having a Peau d'orange. Peau d'orange is T4B. Okay, straightforward question on staging. Peau d'orange is T4B. In operation theatre, a hernia surgery is going on. The sac is found medial to the epigastric artery. So I am now drawing the inguinal ligament. So this is inguinal ligament. Don't forget this is deep ring. This is superficial ring. And this is the inferior epigastric artery going like this, arising from external iliac artery. And this is the rectus abdominis muscle. Therefore, this is known as Hasselbalch triangle. So, question is telling, during surgery of the inguinal canal, the sac is found medial to the inferior epigastric artery. This is the sac. From here only the sac is coming like this. Now tell me what is this hernia. It is a case of medial to inferior epigastric hernia means here. So it is medial means it is coming from here. If it is lateral means it is indirect. Medial means it is direct. Simple question. Medial to inferior epigastric, if I have a sac, it is direct hernia. And always direct hernia needs what surgery? Mesh repair. Lichtenstein's mesh repair is the correct answer for this question. Correct. Very good. So a 50-year-old male presented with a swelling in the right groin while I am occluding the deep ring. So please remember, see this question, see the image, previous image. If I am occluding the deep ring, if I am occluding deep ring occlusion test, the most important test, if I am occluding deep ring, if the hernia appears, it is what hernia? It is a direct hernia. If it not appears, it is indirect hernia. Right? Both are very basic MBBS questions. Hernia related to simple questions. So while occluding the deep ring, the swelling reappears. What kind of hernia is it? The swelling is reappearing is known as direct hernia. So it is a direct hernia. If it is not appearing, it is indirect hernia. It can be also appearing. There is a wrong mistake in this question. It can also, while occluding the deep ring, the swelling reappears as either direct hernia or even in pantaloon hernia. Pantaloon is a hernia containing indirect as well as direct component. So in direct as well as pantaloon hernia can reappear. So but best answer here is B. Best answer is B. Okay, please don't forget this question. 30-year obese male patient presents with complete inguinal hernia and on examination doughy consistency is felt with a dull note on percussion. So the hernia is having a doughy consistency with a dull note on percussion. When I percussion the hernia, there is a doughy consistency. This suggests that the contents of the hernia sac are omentum. Please don't forget, it is a omentum, will have doughy consistency. Bowel will have elastic consistency. So in another interesting point is there in omentum and bowel, how to differentiate. Omentum or bowel in the hernial sac is differentiated by percussion, having doughy in Momentum, elastic or percussion in bowel. Another important thing is when I'm trying to reduce the momentum, the initial part will go easily, but the last part will not go inside. When I try to reduce the bowel, the first part is difficult to reduce, little difficult it will go, but once it goes, all the remaining bowel will go inside. This point is very important. In which condition the reduction of last part is difficult is momentum. It is because the momentum will be adherent to the tip of the sac. So momentum last part is difficult to reduce. Last part is difficult to reduce. Please don't forget this point. So simple question from foreign medical graduate examination. This question was asked as an image based question. Identify the lesion shown in the image. Is going to be leukoplakia. Leukoplakia is a white patch in the oral cavity. It's little easy question. Don't get confused. Leukoplakia has a risk of 2 to 4% risk of malignancy. In leukoplakia, we have one type known as speckled type like this. It will be speckled like that. Speckled leukoplakias will have more risk of malignancy, high risk. It is high risk of malignancy is speckled, okay, speckled type. So leukoplakia is a pre-malignant lesion going for cancer. 27-year-old woman presents with 26 weeks of pregnancy with a thyroid lesion, which is papillary cancer thyroid. What is the best treatment? It is a very simple, straightforward question. Please remember, patient is having a thyroid cancer. She is a pregnant woman. She is having a thyroid papillary cancer now. I cannot use radioactive iodine for her because she is pregnant. Observation cannot be done because it is a malignancy. Hemothyroidectomy will not be done because we don't have the size of the lesion. If the size of lesion is 1 centimeter or 2 centimeter, we can go for hemothyroidectomy. It is not mentioned so. But the answer here is total thyroidectomy is the correct answer for this question. Okay, it's a simple, straightforward question. Many times what happens in exams, you will be seeing a simple question and you will think, okay, there is something, a hitch point here. So it may be this, and you might get confused and you will make a mistake. So very good, Manish, that is correct. It is total thyroidectomy is the correct answer for this question. So I made this test, second test, purposefully little easy because third test is going to be tougher question. The toughest test is third test. We are going to discuss on Saturday, the third test. All of you, I am requesting you, please appear for Elite Test Series 3. We are having 35 questions in that. All the 35 questions are extraordinary, extreme questions suitable for INI set. All questions you can answer only when you have that in-depth knowledge of those topics. So all these test series, Elite Test Series are purposefully made for toppers who already have prepared well and who want an extra bite. These questions will be definitely helpful. Anshul, you have not got aphthous ulcer so far. I'm wondering how come you have not got have aphthous ulcer. Aphthous ulcer is very common among medicos. We commonly get in the lips or tongue. It's like a punctate ulcers. It will be having a severe pain. I'll show you in the next classes. You can verify in the app. It is there. The aphthous ulcer pictures are there. I'll show you if possible. In a 35-year-old pregnant female. Now it's another interesting question from thyrotoxicosis. So 35-year female patient. Pregnant patient again. She is having hyperthyroidism. Which antithyroid drug should be given in first trimester of pregnancy? So you all very well know carbimazole, methimazole are drugs which can cross placental barrier. Therefore, they should not be used. Propylthiouracil is a drug of choice during pregnancy because it does not cross the placental barrier. So can you tell me what is the most dangerous side effect of methimazole and carbimazole? They will cause reversible agranulocytosis. The WBC count can fall down. We should be very careful when we are giving carbimazole 10 mg TDS because we might be giving it for 3 to 6 months. So the 3 to 6 months we should very closely watch for any decreasing WBC count. The patients may develop multiple issues. Okay. So next session on GAT on Saturday. So let me, some of you asked about the aphthous ulcer. Let me show about the aphthous ulcer images. All the ulcer images I'll show you. So I want you to see the ulcers in the oral cavity. All ulcers can come as exam question. So this is an ulcer known as snail track ulcer in the mouth. You get snail track ulcers in syphilis. Okay, syphilis. See the aphthous ulcer. This is a typical aphthous ulcer. Centrally mild slough may be there. It is surrounded by severe inflammation, very common in the lips and tongue. This is aphthous ulcer, mostly seen in stress and vitamin deficiency. This is a gummatous ulcer. You can see in the midline of the tongue there is a gummatous ulcer. Gumma patients will get this. Syphilis patients. So you can understand aphthous ulcers are multiple small, painful, shallow ulcers. Dental ulcer seen on the lateral margin of the tongue. TB ulcer in the tip of the tongue. Gummatous ulcer is seen in the syphilis. Cancer ulcers are painless ulcers. Okay. On the oral, this is leukoplakia. You can see here, white patch. This is a speckled leukoplakia. I told you speckled. This is speckled leukoplakia again. This is erythroplakia, red velvety plaque. Okay. So all these oral cavity lesions are asked in the exam. So please go through the app. In oral cavity chapter, I have shown all these images. Okay. So that's about the chapter. So we will see you on Saturday. Thank you, friends. Thank you all. Take care.